Shaan?
Thanks. Good afternoon, everybody. It's an honor to be included in the session today. And sort of building on Dr. DeMonte's comprehensive talk, what I wanted to cover really was the role of endoscopy in the management of skull-based malignancies. And sorry, one second. The way I think about the skull base, certainly, from the neurosurgical perspective, we're taught to think about the skull base in terms of the anterior, middle, and posterior fossa. But when it comes to these malignancies, as Dr. DeMonte alluded to earlier, these are really multi-compartmental malignancies that not only involve the bony skull base, but simultaneously involve the intracranial space and the subcranial compartments. And so I like using this zone-based classification system that was proposed by the University of Toronto group quite some time ago. And essentially, zone 1 malignancies really consists of sinonasal malignancies that involve the anterior skull base and the intercranial space. Zone 2 really consists of the anterolateral skull base malignancies that involve the middle cranial fossa and the infratemporal fossa. And Zone 3 really primarily consists of the temporal bone and posterior fossa malignancies. And certainly, for the central skull base and anterolateral skull base malignancies, Zone 1 and Zone 2, there is a role for endoscopy, but in the interest of time, I'm mainly going to focus on the role of endoscopy in the management of sinonasal cancers with skull base involvement. As Dr. DeMonte indicated, there really is a wide spectrum of histologic diagnoses that involve the sinonasal cavity, and they really behave across a clinical spectrum. On one hand, you have the Hyams grade 1 esthesioneuroblastoma that have a relatively indolent disease course, and when they recur, mainly at risk for local recurrence. And on the other hand, you really have the SNUCs and some mutations where these patients are not only at high risk for local recurrence, but also metastatic disease spread and have extremely poor survival. And it's these differences in behavior that really account for the differences in multimodality treatments that we use, where for patients at high risk of metastatic spread, we discuss using induction chemotherapy and adjuvant chemotherapy as opposed to diagnoses such as esthesioneuroblastoma, where the goal of therapy is predominantly local control. We're primarily relying on surgery and radiation therapy. But not only do these malignancies behave across a biologic spectrum, they also present across an anatomic spectrum with varying degrees of bony skull base and intracranial involvement. And from the surgical perspective, how does one design a surgical strategy to achieve the goals of surgery? It's important to have a rational approach. And given the growing role of endoscopy in the management of central skull base malignancies, having an understanding of the anatomic considerations that need to be factored in terms of not only how to achieve negative margins, but when to do an endoscopic approach versus an open approach is important. And that's essentially what I'm going to cover today. When we discuss the role of surgery with any malignancy, the goals of surgery are very clear, and they're listed here on the left. Ultimately, the goal is to achieve an adequate oncologic and anatomic resection with negative margins. You want to protect critical neurovascular structures and protect neurologic function. Ultimately, with these resections, you're left with large defects, and so the ability to perform a vascularized reconstruction of the skull base is important. And as aesthetics and quality of life outcomes are also important. Now, in the era of minimally invasive surgery, it's important that the aesthetics are not over prioritized over the first 3 goals of surgery. And ultimately, for any resectable lesion, if you select the right surgical strategy, you should be able to achieve these 4 goals. The other point that I want to make on this slide is that the first operation for any patient with a malignancy has to be their best operation. Quite some time ago, our head and neck partners had looked at their experience with sinonasal cancers, and what they found is that those patients presenting newly diagnosed for their first operation, of course, had the best outcome. What was interesting is these patients presenting with persistent disease, so patients presenting with a subtotal resection elsewhere, and then coming to MD Anderson for a definitive resection before proceeding with the rest of the therapy, had far worse outcomes. And I think this is a testament to the fact that once the anatomic boundary of a tumor are disrupted, it becomes harder to salvage those patients and achieve margins. So again, that first operation needs to be the best operation for any patient with a malignancy. Now, we know that achieving negative microscopic margins has a significant impact on long-term outcomes for patients with sinonasal cancers. Anatomically speaking, there are numerous obstacles to achieving negative margins with sinonasal malignancies. Certainly the 3-dimensional topography of the paranasal sinuses, the degree of orbital involvement involved in the nasolacrimal duct, pterygopalatine fossa involvement, and extension to the infratemporal fossa, all are anatomic obstacles in the subcranial space. When we look at the skull base and intracranial space from the neurosurgical perspective, the considerations with regards to achieving margins is the degree of perineural invasion, not only along the olfactory bulbs, but also along the vidian and V2 nerves. The degree of bony skull base involvement, dural, subdural disease invasion, and brain invasion are all considerations with regards to achieving negative margins, and also in terms of designing a surgical strategy. Given the simultaneous involvement of the intracranial space and subcranial cavity, we certainly have seen an evolution with regards to surgical approaches. And as Dr. DeMonte indicated earlier, really the open craniofacial approach, combining a bifrontal craniotomy with a transfacial incision or a midfacial degloving, was really the workhorse with regards to how a lot of these malignancies were tackled with these multidisciplinary cases. And in 2005, there was this international study that was published looking at 1,300 patients, and this really set the gold standard for surgical outcomes. And the results from that paper, matter of fact, were somewhat sobering in retrospect. When you looked at negative margins were only achieved in half of patients, and this came at the cost of surgical complications in nearly a third of patients, with neurologic and wound-related complications being the most common. And these patients were operated on at outstanding surgical centers. And I think this data really highlighted at the time that there was a need to evolve surgical strategies for these sinonasal cancer patients. And that's where we've certainly seen tremendous evolution on several fronts with regards to the management of these malignancies with skull base involvement. One of those advancements was really the introduction of endoscopy. And the endoscopic endonasal approach was initially introduced as a replacement for the transfacial approach. And it was initially introduced as a way to clear margins in the subcranial space. And the rationale for introducing endoscopy was that essentially it enhanced visualization of the sinonasal cavity and made it easier to clear margins in the subcranial space. Also, it allowed the ability to clear margins in the subcranial cavity while avoiding facial incisions and any facial translocations, and hence essentially avoiding those wound-related complications that were seen frequently with the open craniofacial approach. With advancements in endoscopy techniques and surgical technique, we're of course now able to employ the endoscopic approach not only to clear disease from the perinasal sinuses, but from the skull base and intracranial space. And certainly a fair amount of the work that we have going on within our own program here is really trying to figure out what the role of endoscopy is relative to transcranial approaches in the management of sinonasal malignancies, specifically when there's involvement of the skull base and intracranial space, and really trying to figure out what the anatomic considerations are. So what I'm going to do is at least first provide an overview of the technique that we use to resect skull base involvement and intracranial disease, and then talk about some of the factors I look at in terms of trying to figure out an endoscopic versus an open approach. And so this is an example of a SNUC patient with involvement of the bony skull base and dura, and you can see involvement of the lamina propria here in the orbit and the periorbita. And so this patient was taken for an endoscopic resection, and conceptually, the way we think of these operations is that while we can't do an en-bloc resection, the goal is to achieve an anatomic resection. And so the thought is to essentially open up each anatomic compartment that the tumor is involving and take margins at the anatomic boundaries of those disease compartments. And so here we are starting in the midline. This is my head and neck partner who's doing some gentle debulking of the tumor. And after debulking the tumor, margins are then taken along the mucosa of the nasal septum. And once those margins are cleared, as you'll see, eventually we'll start working lateral to the tumor along both maxillary sinuses. And margins are taken from both maxillary sinuses, and then eventually the sphenopalatine arteries are identified bilaterally, bipolared, and then clipped in order to devascularize the inferior portion of the tumor. Mucosal margins are then taken from the nasopharynx and then from the sphenoid sinus. And at this point, essentially the margins are then cleared below, lateral, and posterior to the subcranial component of the tumor. Here I am taking septations down the sphenoid sinus and identifying the optic canals at the posterior aspect of the tumor. And then forwarding the video a little bit. At this point, we're taking down the lamina propria on both sides. The advantage of this is that this not only clears disease away from both orbits, but also allows for identification of the anterior and posterior ethmoidal arteries as they traverse from the orbit towards the sinonasal cavity, and eventually allows you to devascularize the superior pole of the tumor much earlier in the operation. And the last portion of the subcranial portion of the operation is really opening up the frontal sinuses via draft through frontal sinusotomy. This allows you to clear any mucosal disease from the frontal sinuses, and then this also facilitates the skull base resection, because at this point, we've opened up both ethmoid sinuses, so that delineates the lateral aspect of our skull base resection. By opening up the frontal sinus, that really is the anterior-most aspect of the cribriform plate, and so that will delineate the anterior-most aspect of our resection. And then also by opening up the sphenoid sinus, which we did earlier on in the operation, that delineates the posterior aspect of the skull base resection that eventually I'll do. And so forwarding ahead here. So this is sort of the planned extent of the bony resection that I do, going from the frontal sinus all the way back to the optic canals and going from orbit to orbit. And so here I am then doing a craniectomy of the skull base, working along the just anterior to the optic canals and resecting the planum sphenoidale. Then resecting the fovea ethmoidalis bilaterally and taking down the ethmoidal arteries. And you can see by taking out the lamina propria, you can also gently retract on the orbits and resect a little bit of the orbital roof bilaterally in order to enhance that bony resection along the skull base. And after completing the bony resection, ultimately what you're going to be left with is the soft tissue attachment of the tumor to the dura. The last portion of the bony resection here is resecting the crista galli. And at this point, then basically circumferential incisions of the dura are then performed along the anterior skull base. For this a little bit, you can see some tumor tracking along the right olfactory bulb. The frontal lobes are dissected from the falx, and the falx is then transected. And then you can see both olfactory bulbs are being dissected from the frontal lobes. And then after sharply transecting both olfactory bulbs, you can see that the skull base component of the tumor has been resected then. And then margins are taken from both olfactory bulbs and the circumferentially from the dura. And you can see you can certainly dissect epidurally above both orbits to enhance the dural margins there. Now, moving on to the reconstruction, after confirming that margins are microscopically negative on intraoperative pathology, you're often left with this large defect like this, where the frontal lobes are exposed all the way from the frontal sinus back to the optic canals and going from orbit to orbit. And the goals of reconstruction are very clear, whether you're doing an open approach or an endoscopic approach. And certainly we learned from the open era that using vascularized tissue, and we historically relied on pericranial flaps for anterior skull base resections, really is the best way to reconstruct these large defects. And I know that there's several endoscopic programs out there that will use, for example, fascia lata only to reconstruct skull base defects. In addition to using lumbar drains, what we've also learned is that having healthy vascularized tissue is also a great way to reduce CSF leaks for these large endoscopic resections. And so with regards to the resection, what we typically do is a multi-layer closure using fascia lata that is sutured and tucked into the subdural and epidural space. And after sort of halting a CSF leak at that point, then do a bicoronal incision and then harvest a pericranial flap that has a unilateral pedicle. And in order to tunnel this into the nasal cavity, what we do is create a bony window at the nasofrontal suture, which is a good delineator between the intracranial space and the subcranial space. And then the pericranial flap is then tunneled into the nasal cavity and then secured up against the skull base. And you get a nice view of that with a nice pulsating defect. And that is sort of a sign of a good, healthy reconstruction at the end. Now, what I've shown you is the endoscopic approach that we use for extensive sinonasal cancers with bony and subdural involvement. The fact of the matter is, as I indicated earlier, is that these really sort of present across an anatomic spectrum. And so you can have limited sinonasal cancers that have really no bony skull base involvement, and they extend all the way up to those that present with brain invasion. And given the increasing role of endoscopy, it's important to recognize that the resection can be certainly tailored when you're doing an endoscopic approach. And so the way I like to think about these sinonasal cancers when designing an endoscopic approach is you can certainly have a limited sinonasal malignancy such as this one, where they're primarily in the paranasal sinuses and there's really no involvement of the bony skull base. And when I look at an MRI scan like this, what I think about is really the compartments that are going to be opened up to achieve margins are all in the nasal cavity and the sinuses. The next level up are the sinonasal cancers that extend up to the bony skull base, but there's clearly no evidence of dural or subdural disease involvement. When I plan for these cases, in addition to achieving margins in the paranasal sinuses, what I plan on resecting is really the bony skull base, the cribriform plate and the fovea ethmoidalis, and then taking margins along the olfactory phyla within the nasal cavity to determine whether or not the dura needs to be opened up to achieve margins. But ultimately, in these cases, at most, what needs to be resected, the skull base, is really the bony skull base. The next level up in terms of complexity endoscopically is what I showed you in the video, is those with dural and subdural disease involvement. And in these cases, in addition to resecting the perinasal sinuses and the bony skull base, I also plan, of course, resecting the anterior skull base dura and the olfactory bulbs. And then the more complex sinonasal cancers are those that have not only involvement of the bony skull base and the dura and the subdural space, but also have brain invasion. And in these cases, while we may resect the subcranial portion of the disease endoscopically, as soon as there's presence of brain invasion, this is typically where we think about adding on a bifrontal craniotomy to supplement the endoscopic approach. Now, there are also lateral modifications. A lot of these malignancies can have perineural extension along the Vidian nerve or along V2, as you can see with this adenoid cystic carcinoma. These can still be tackled endoscopically, and in these cases, what I plan on doing is a transpterygoid approach where the pterygopalatine fossa is opened up, the Vidian can be identified, and V2 can be traced off. And this is an example of a right-sided transpterygoid approach where all the bone overlying V2 is being skeletonized before it's dissected back to Meckel's cave and transected for margins. So here's a look at our endoscopic practice when we look at sinonasal cancers. The T3 and T4 malignancies are sinonasal cancers that involve the skull base. And when you look at our endoscopic sinonasal cancer practice, nearly 60%, 65% of the cases that we're doing endoscopically are these more advanced sinonasal cancers. And this certainly highlights the role of endoscopy in the management of more anatomically extensive malignancies. Now, when we look at all sinonasal cancers, irrespective of practice, you can see that in 30% of cases, we're still adding on or using an open approach and not doing purely an endoscopic approach. And this really highlights the ability to use the full spectrum of surgical approaches is important if you're going to try to achieve those goals of surgery. So when do we think of using an open approach? So this is an example of a case where we used an open approach. This is a patient with a esthesioneuroblastoma. This is a Himes grade 4 esthesio. And the reason why we did not do this endoscopically is that there was disease involvement of the anterior wall of the frontal sinus. There's disease involvement of the dura along the posterior wall of the frontal sinus. These are both areas that are hard to clear with wide margins endoscopically. And also, it's hard to appreciate on this MRI scan, but there was disease involvement of the nasal vault, the facial skeleton. And so as a result, what I did was I resected this by a transcranial endoscopic approach. And this is viewed by the transcranial approach. And to reconstruct the nasal vault, the bony nasal vault that was resected, we did a radial forearm flap to reconstruct that bone, in addition to a pericranial flap that was placed over that. Another example where an endoscopic approach would be inappropriate. Understanding the epicenter of the disease process is important. So this is a patient that had presented to me, and looking at the coronal view of this MRI scan, you would think that this is just a run-of-the-mill sinonasal cancer with some limited bony skull base involvement. But a matter of fact, what this was a malignancy arising out of the lacrimal sac along the inferomedial aspect of the orbit. So not really a sinonasal malignancy, but more of an orbital malignancy. And in this case, it certainly was inappropriate for an endoscopic approach, and we resected this via an open approach. And so there clearly are anatomic considerations that need to be kept in mind when deciding between an endoscopic and open approach. This is data that Dr. DeMonte showed you earlier. And recently we looked at our 239 sinonasal cancers and looked at outcomes between those resected purely endoscopically and those resected by a combined endoscopic open approach. And what we found was that there was no difference in negative margins and surgical complications between the two. Now, the take-home point of this paper really is that surgical decision-making is important in terms of deciding when to do an endoscopic versus when to do a hybrid open endoscopic approach and versus when to do an open approach. And it also highlights the evolution that has occurred with regards to surgical resection, because these outcomes certainly are much better than that international paper that I showed you from 2005, where negative margins were only achieved in 50% of patients with a 33% risk of complications. So to wrap up, certainly understanding the role and the rationale for multimodality therapy for these different sinonasal cancers is important, and understanding the biology of the diagnosis is important. From the surgical perspective, we've certainly seen tremendous development with regards to open and endoscopic approaches. It's important to understand that the goals of surgery are the same for any malignancy. and that there clearly is a role for the full spectrum of open and endoscopic approaches in terms of treating this patient population. So once again, thank you so much for having me, and I think happy to take questions later on during the question and answer session.